All right, thanks guys. We might get started here. So I'm Michael Troop, for those that haven't met me. You've probably seen me running around the conference organising some things. Yep, that's me there. So just a few announcements before we get started. So just briefly, for the public prize that David was mentioning before, for the poster sessions, at 3 p.m. we had only 3 votes. So if everyone, if you've seen a poster you've liked, please, there's some flyers outside with the website about how you can go to vote. Or this is it here again. So it's tinyurl.com/ASSC18. And just a reminder, we have those stuffed animals as a prize, and also the raffle to be able to come to the main dinner if you don't already have a ticket. ASSC, sorry, tinyurl.com/ASSC18 vote. We also have, so the main dinner tonight, a lot of you already have tickets for that. And Bruno mentioned before the poor man's dinner. So I tried to get this renamed the egalitarian dinner, but it didn't catch on. But we really want to try and get as many people there as possible. So if you haven't signed up for it, but you still want to come, don't worry about signing up or paying at the moment. Just get on the bus, come to Lone Pine, and worry about payment later. We've also sweetened the deal, so we've added a $500 bar tab as well for beer and wine for the dinner outside. So hopefully that'll coax a few more people into it. Just in terms of some of the logistics, so we're going to be a bit strapped for time, especially for the people that are catching the ferry. So here's a map everyone has in their conference booklet. So this blue circle is where the boat's going to leave from. So note that it's not the ferry terminal where some of you might have caught a city cap from. It's further on up, so it's going to take, it might take a little while to walk there. So we're going to try and have a group of people guiding everyone, making sure that you can get there. It's probably going to be cold, so for those people that need a jacket and haven't got one, who are staying at the women's college or something, that need to run back and find a jacket or powder their nose or whatever, just be aware that you need to get there by 5:30, so it is a bit of a rush.
We will wait.
This should end at 5 o'clock in theory. Yeah, and so the ferry will leave at 5:30.
5:40.
Yeah. So there's also buses. So everyone that isn't on the ferry can get there by bus, and the buses are leaving from the Chancellor's Place bus stop. So everyone that's already been to QBI to building 85 to have their poster printed already have probably walked past this. It's that road going along there where all the buses come in and out of. So we've got 2 buses leaving at 6 o'clock from there. So everyone that's not on the ferry needs to make their way to those buses. If you miss the ferry, you could try to make the buses, but we're also going to sort of be driving around as well, seeing if there's any stragglers that we can pick up. Oh, sorry, one more thing. So we plan to meet on the lakeside lawn, so for everyone that's getting the ferry, just where the sausage sizzle has been held for the lunch times, if everyone can gather around there so we can go as a group and make sure no one gets lost or anything, I think that'll speed up getting everyone there too.
When do we gather there?
Straight after. Yep.
What about this so-called poor man's dinner?
The poor man's dinner? Yep, so if you're going to the poor man's dinner, you're on the bus. Yeah. No ferry for you. Right, I think that's all.
There's several buses back.
Yeah, and there's buses back as well, so there'll be shuttles back and forth. And they do stop at a public transport sort of hub on the way back, so everyone that wants to come to the dinner and then go out later, it's easy to catch a bus from one of the stops. We'll be stopping out straight into the city or something.
Is there a ferry back?
No. All right, let's get started then. So it's my great pleasure to introduce Emery Brown, who's the Edward Hood Taplin Professor of Medical Engineering, the Professor of Computational Neuroscience at MIT, the Warren M. Zappo Professor of Anesthesia at Harvard Medical School and Massachusetts General Hospital, and an anesthesiologist at Mass Gen. He received his bachelor's degree in applied mathematics from Harvard College, his master's and Ph.D. in statistics from Harvard University, and his M.D. from Harvard Medical School. He has made many conceptual and experimental contributions to the neurophysiological understanding of general anesthesia, and has developed signal processing methods to solve key data analysis challenges in neuroscience. And in fact, these diverse areas of his interest caused some confusion recently. So recently, QBI hosted Emery for the neuroscience lecture series on Wednesday, and some of you I know went to that talk. And the lab that hosted them, the Goodhill lab, headed by Jeff Goodhill, is a computational neurosciences lab. What we study in Bruno's lab, we look at general anesthesia. So when Jeff mentioned to Bruno that Emery Brown was coming to give a lecture, Bruno was a bit surprised. Emery Brown, the anesthesiologist, no, this guy's a statistician. He does mathematical modeling of neural systems. We must have different Emery Browns then. So it wasn't until they came back later that they worked out, oh no, this is the same person. And it seems that he's a leader in not one, but two separate areas of neuroscience. I think that's an amazing example of the diversity of his research. So he also serves on the National Institutes of Health's Brain Initiative Working Group, is the recipient of an NIH Director's Pioneer Award and an NIH Director's Transformative Research Award. He is a fellow of the IEEE, a fellow of the American Academy of Arts and Sciences, a member of the Institute of Medicine, and a member of the National Academy of Sciences. So I'm really looking forward to hearing what he has to say about general anesthesia.
Okay, great, thanks. So, thanks very much. Thanks for the introduction. Bruno, thanks for having me, and thanks to the organizers for inviting me. It's my first chance to visit Australia. It's been great. And thanks to Jeff for having me the other day for the lecture. There's only one of me. They're not two. So I'm going to talk about this work that we've been doing, looking at what happens to the brain under anesthesia. And the conceptual framework that we use is we treat it as a neuroscience problem. And although that might be obvious to this crowd, for anesthesiologists, we think of anesthesia as being a pharmacological problem. You know, we try to dial in the right amount of drug. We think about the drug in the blood levels, or the lung levels of the drug, and we use that to guide our thinking. When in point of fact, what we should be doing is thinking about how it affects the brain. And so that's what I want to chat about today. So this is just to mention the support that we've had. We've had good fortune to have support from a number of sources. A couple of those Michael mentioned. So this is the outline that I'm going to follow. First, I want to just give you a clinical sense of what anesthesia is like, what happens to patients under anesthesia if you haven't seen it, or if you have seen it, just to remind you about what's going on so we can focus on the questions specifically. And then I'm going to speak specifically about loss of consciousness under propofol. It's a drug we've studied in detail. We've studied the other drugs, but I want to talk about that one in detail because we've gone the furthest in terms of, at least in our work, in trying to characterize it. Then I want to speak about something like reanimation from anesthesia. We work very hard to induce anesthesia, to keep you anesthetized, and what I think we should also think about is how can we wake you up. And then I'll just have a couple concluding comments. So let me just begin by saying that I'm going to talk about a small amount of research that we've done, but this is an extremely active field. And I just went and sampled, last night, just some papers that have been published in the last, 10 years or so. And if you look even over the last, like 2 or 3 years, it's just been a lot of work in this area. And I think for me this is very, very exciting because it means that, the anesthesia is being viewed now as a neuroscience process. And many of the experts, or several of them, are here, like Jamie Slay is here, Giulio Tononi is here, Marcello Massimimi is here. So you can also get their perspectives on this as well. And I think it's going to be a field that's going to grow and be exciting. And one of the reasons I mention that for the students because it might not be something that you're thinking about investigating. But I think the opportunity is to go into an area where we really need smart people to come and think about it. Basically, this is it because there's not the density of people with neuroscience background studying anesthesia as there should be. All right, so let's just start with a clinical look. So before I give a clinical look, I just want to go through a definition. So here's a definition of general anesthesia. It's not the most universally accepted definition, but it's one. So it's a drug-induced reversible state that's you're not supposed to be aware. It's nice if you don't remember. It's cool if it doesn't hurt. It's probably also nice if you're not moving around while the surgeon is operating. But if you stop right there and you forget about the reversibility, then this is all synonymous with death. All right? All right. So here's where we earn our money right here, from control and stability of the physiological systems, and the fact that we can bring you in and out of, bring you in a state of anesthesia and then bring you out. You know, we like to say that it's often said that how anesthesia works is not known. And what I want to just convince you of is just by doing a little bit of simple Gedanken experiment, no research, just a little bit of Gedanken experiment, we can learn a lot about how the drugs have to be working, and move from there to actually look at some experimental work. So how many people here have actually had anesthesia? Oh, well, you've seen it from the other side then, all right? And how many people have actually seen someone else get anesthesia, aside from the anesthesiologist? Okay. All right, so I'll fix that here for the rest of you. So this is just a little video I want to use just to illustrate the idea of someone becoming anesthetized. So this is one Friday afternoon. My colleague Eric Pierce and I just went over to film someone
this
going
is what I'm
off
going to
on
ask you to do as you go off to sleep.
So this gentleman is 68 years old. He has had surgery before. He has a small umbilical hernia right here, which is going to be repaired under general anesthesia. You could do this under local, but he was going to have it under general anesthesia. So I'm going to do a few maneuvers with him because I'm going to show him a few things that I want him to do when the induction takes place. So the first thing I had him do is just track my finger, just doing smooth pursuit of my finger.
Okay. And now let me just check one other thing here. What I'm going to ask you to do is, so I'm just going to turn your head. Just let me turn it, okay? You don't have to do it. I'm going to turn. Yeah, there we go.
Right.
Good. I'm going to turn your head.
So I'm just checking his oculocephalic reflex. And just to remind you, those who haven't thought about this a while, so in normal, the doll's eye oculocephalic reflex, you turn the head one way, the eyes go the other. You turn the head the other way, the eyes go back in the opposite direction. And it's a quick check for looking at what happens at the brainstem. We're going to use that in just a second, all right?
Get him to do it 2 more times, 1 more time. Okay. I'm going to pull down, you pull up.
Do you mind giving a little midazolam?
And so right here, I just want to show you, he's got normal motor strength. There's also a chance to bond with the patient before we start.
Open your mouth a little bit if it helps, okay? This is the most important thing we're going to be doing for you before
So
you go off.
if you've never really watched this before,
and then forcefully blow.
So what the nurse is doing now, this is a nurse anesthetist, Susan Schindler, is taking care of the patient. She's going to have him breathe oxygen for about 2 to 3 minutes. And the reason we do that is to create a safety margin, because typically when we have difficulties in anesthesia, it's usually on induction. And meaning the way we do it is we make the person unconscious, we give a muscle relaxant, and then we try to take over the ventilation. If it's difficult, if that doesn't work, then we have a problem. If we have someone who's profoundly unconscious, who's not breathing, and we can't ventilate them. So we try to create a margin of safety by having them breathe oxygen for a bit. So that's what she's doing now. It's called denitrogenation or pre-oxygenation.
Another deep breath, as deep as you can, and blow out.
So I want you to just watch it.
So now I'm going to ask her to
You may
ask
feel
him to
warmth
track
in your
his finger.
arm.
And what I'm going to
completely
ask you
normal.
to do is, if you can no longer do it, I want you to tell me. You tell me if you
So
can
when
no
the
longer
words
do
came
it.
on the screen, he just got a bolus of propofol, about 150
Fantastic.
milligrams.
Just keep doing it. Just keep doing it. That's great. If you can no longer do it, just tell me. Sir? Sir, can you hear me?
I'm just going to give you a deep breath here, okay?
Okay, so she's got to breathe for him now because he's unconscious. He stopped breathing. And I'm going to turn his head. Look at his eyes. See, they're fixed in the midline. Okay? They're fixed in the midline. And he's not breathing. He's not responsive. His eyes are fixed in the midline. And then watch this. You hear the beep, beep, beep. He's still alive. That's his heartbeat. Just, you know. Let's keep to the basics first. All right, all right, all right. But so his eyes are fixed. But watch his arm now. This is just with propofol. So it's totally flaccid. Okay? All right, so his arm's flaccid, he's unconscious, and his eyes are fixed in the midline. So very robust clinical signs, all right? All right, we're going to play neurologist in just a second. All right. But now, when I made this video, I did not film his EEG, okay? So what I want to just show you is the EEG of someone who's going through exactly the same thing, just to give you a sense of, because I want to match up what happens electrophysiologically with what we just saw clinically. So this is a lady that I was taking care of in the operating room. She's about 62 years old. She weighs about 80 kilos, and she's coming to have a thyroidectomy. And we're going to do exactly the same thing to her. I'm just give her a bolus dose of propofol. And this is one of the monitors we typically use in our operating room. It has 4 leads of EEG, so we can track the EEG of all of our patients as they get anesthetized. So I'm going to administer she's going to get the propofol right now. And you see, those are eye blinks, so those of you who are not familiar with it, and you probably know more about EEG than I do. All right. Now, there's one thing you're going to see here in just a second. Propofol, when it's administered, burns when it goes in, particularly a small vein. And even Michael Jackson knew this. In fact, when he was getting propofol to help him sleep, he would ask, "Are you going to also give me the numbing medicine first too, because it's burning?" Because after they'd used it on him for such a long period of time, they had trouble finding veins, and so they're putting it in veins sort of everywhere. So he would always ask for lidocaine beforehand to numb his veins up, to numb the injection site up before he got the propofol. All right. So you're going to see that in just a second. So you see this here, this EMG activity? That's because it's burning as it goes in. And you can see the EMG going up here. All right? Now watch what happens right here. You're going to see the EEG change abruptly. See right here? I'm going to freeze this right here. So it went from this sort of fairly irregular activity, part of it was his EMG, now to like a very well-defined beta oscillation, okay? Now watch what happens next. It's only a few seconds. See these slow oscillations start. I'll just freeze them right here. There they are. Okay, just a few seconds later, all right? Now I'm going to let this play out just for a couple more seconds. She's in burst suppression, all right? So very profound state of anesthesia. When people are placed in medical coma, this is what you do. You dial them down to this state of anesthesia to protect the brain or to try to treat a seizure, all right? So she's profoundly unconscious. That wasn't even a full minute yet. And she's in a very, very profound state of unconsciousness, all right? One thing I wanted you to see is these changes are obvious. They're not subtle. You don't have to squint to see these. So it suggests that whatever is happening here has to be very profound. It has to be affecting large numbers of circuits simultaneously. All right, so let's just do a little bit of anatomy here and just maybe do some reasoning about what might be going on. So here's the brain turned upside down. All right, so here's the basilar artery. As you know, the basilar arteries form from the 2 vertebrals which fuse and then travel on the underside of the brain. So it's traveling here. So if you look at it in this projection here, it'd be traveling right along there. All right. So what's the first thing that it would run into as it came up coursing by the medulla and the pons here? But it runs into these blue dots here, which are the ventral and dorsal respiratory groups. All right, if you look at the anatomy, the neural circuitry of that, it's a collection of inhibitory and excitatory neurons, all right? Propofol is a GABAergic drug. And so if you have inhibitory interneurons that are sitting there and they have a chance to have a GABAergic drug help them out, then what's going to happen is you're going to actually shut down the respiratory center, and that's precisely what you saw. One of the first things we saw was this gentleman stop breathing. Now, as this courses up through here, projects all along here, then the next thing that you run into, which there's a color code to this. These are the cholinergic centers which are sitting here, lateral dorsal tegmental area, peduncle pontine tegmental area, then the basal forebrain sitting here. These are the arousal centers that project up to the cortex that give off cholinergic neurotransmitters, acetylcholine. And then here, the guys in the middle, with the exception of this guy here, are the monoaminergic ones, all right? Now, the clinical link. You saw that his eyes fixed in the midline. So, neurologists look at this all the time. They examine the eyes. They could care less about the eyes. What they're trying to do is make an inference. They're trying to make an inference about maybe there's some damage to some part of the brain. So one of the things that they're trying to make an inference about in this case is if you look at where the nerves that control the nuclei which control the movement of the eyes, cranial nerves 3, 4, and 6, 3 and 4 are sitting here in the midbrain, and 6 is sitting right here at the pons, just below the midbrain pontine junction. So there's an inference. The inference is that if something has taken out your ability to move the eyes, perhaps what it's also done is also altered arousal. And that's exactly what we saw. When he lost the ability to track, he also became unconscious. All right? So we have an idea about why that may have occurred. And I'll just tell you here, just to foreshadow a bit, each of these nuclei, pretty much all of them, has a GABAergic projection onto them coming from the preoptic area of the hypothalamus. So again, a target for propofol coursing through the brainstem there. And the final bit, which is maybe a little less obvious, is, and I put my friend up here because NASA is interested in this. And if you've ever, I mean, we don't have any shuttle launches from the United States anymore, but when we used to have them, when the shuttles would land, you know, they go, this was another successful shuttle mission for Discovery, another great accomplishment for the U.S. space program, right? And then the TV would go off, right? You'd never see the astronauts hop out and give a press conference right after they landed because they're like spaghetti. They've been in zero G's for so long that they have basically lost control of their central motor function substantially. And there are a number of reasons for it, but one of them has to do with these relay nuclei here that are sitting in the pons and also in the medulla, which are responsible for control of the anti-gravity muscles, so the long muscles of the arms and the legs. And our neurology colleagues will tell us that when you get a clot, like in the basilar artery here, and you take it out, and you take out the blood flow going to this area here, when the patients present with a stroke, they don't present spastic, they actually present with a flaccid paralysis. So we can make an inference about what's happened to this guy here. Now clearly, propofol is acting at a number of different sites, but I just want to point out there's good reason to just clinically reason that there's a strong effect here in the brainstem. All right. Now, so let me just show you what the EEG looks like here. So that's someone awake. That's about 5 microvolts or so. Now, what's interesting about someone under anesthesia is the EEG changes tremendously. I mean, I just showed you that. And in fact, it goes up to about 50 microvolts or so. Here are those slow oscillations I showed you. And this is what I'm going to be talking mostly about, these alpha oscillations and slow oscillations here combined. This is burst suppression down there. I'm not going to say too much about that. And I showed you what the isoelectric state looked like. And this state right here, this one here, is this kind of beta oscillation I showed you in the beginning. All right, where just before the slow oscillations came on. All right, so going from about 5 microvolts here up to something which can be as large as 50 or 100 microvolts, or in the case of kids, right? In kids, 2,000 microvolts very easily. All right? All right. So here's the way we look at it in the operating room. All right? So this is the spectrogram. So power over time by frequency. And so this is someone who's gotten a bolus dose of propofol here and then maintained on propofol. And this is going to be the sort of the main signature I'm going to talk about, the fact that you have this 10 hertz oscillation here and this slow delta oscillation here. This is very, very typical. So this is what the slow oscillation looks like just after induction. Then you go into the state of 10 hertz and slow oscillation. As long as you maintain the propofol infusion, you stop it and it dissipates and the patient eventually recovers. And this is a lady that I was taking care of the operating room here, did the induction with propofol. All she needed was an examination under anesthesia. And so she's moving a bit, and the surgeon says, okay, I can't do my exam. She needs some more propofol. So I give her some more propofol. He goes, I'm done. All right? So now, everything that happened from right here on, right, starting from this point on, is just with drug that was given right here. And she goes into burst suppression. That's what all this breaking up in the line is. Then she goes into the alpha oscillation and the slow oscillation. Then she finally recovered over here 30 minutes later. So the brain went through sort of 3 dynamical states, which you can easily see there. All right. Now, so what I want to point out is that everything I've just said has been known for years. All right. So this is from a paper in 1937 by Gibbs, and Lennox, in which they pointed out right here that in ether anesthesia, when a surgical level is reached, slow waves have a frequency of about 1 cycle per second. And superimposed is a small, faster wave with a frequency of about 10 to 20 cycles per second. And the slow waves have a cremated appearance. A practical applications observation might be the use of the EEG to measure depth of anesthesia. You could use it the same way the surgeon, you use the electrocardiogram to track the cardiovascular system. All right, so we're just rediscovering the past. All right, so now that's the clinical picture. So this is work which has been done primarily by Patrick Purdon, my colleague for a number of years, and also Sid Cash, who's a neurologist at MGH, and Ahmad Eskandar, who's our neurosurgeon at MGH. So I'm just going to tell you about a study which we did a few years ago, in which we wanted to image patients with functional magnetic resonance imaging and look at the EEG simultaneously while people were under anesthesia. But we wanted to be sure they were profoundly unconscious. And one thing that I just showed you in the video is that when you anesthetize someone, they stop breathing. So we had to come up with a way that we could have patients that could lose consciousness, and we could still continue to control their breathing in an MRI scanner while we were administering the drug and making all the other measurements. And so what we did was we got people to volunteer who had tracheostomies. So these were people who had tracheostomies because they had had thyroid, they'd had maybe laryngeal cancer, they may have had a traumatic injury to the larynx, and they had maybe a dysplastic growth removed. And so what we could do is put like a tracheostomy tube in place and then just hook them up to the ventilating machine before we started, and then put them in the scanner. And if they stop breathing, just ventilate through and just continue with our measurements. That's basically what we did. Then the protocol was very simple, just giving increasing doses of propofol, holding each level for about 10 to 20 minutes or so, and then increasing, and imaging, and also measuring EEG at the same time, while we're having to execute a simple behavioral task, which is a yes-no question, hitting a left button for one type of a yes and a right button for a no, so we could have a binary indicator of when people were losing consciousness. And then we were thinking very naively at the time, because we thought, all right, so we're activating the auditory pathway, we should see the auditory pathway lighting up, and then parts of it should just dissipate out, all right? So here's basically what we found. Here's the auditory pathway, which is activated. These are some of the composite images taken from the study. The auditory pathway is quite active. Persons just before losing consciousness is quite active. This is an average over the 7 subjects that we studied. It's quite active here in this segment. You can see it here again in this sort of coronal segment here. There's a place here where there's seemingly no activity, and that's not that there's no activity, it's just that that's the threshold. The activity is not above the threshold that we set. It's the same threshold across all the images, nothing fancy. But this was the part which is quite unexpected, was that these lower brain areas were actually quite active once the person was profoundly unconscious. Now, this was a bit surprising. And in particular, one of the things that we discovered was that it seemed that the thalamus was, in particular, was quite active. And again, as you know, one of the ideas which has been around in the anesthesia literature for a while, Michael Alker has pointed this out, if you wanted to take out one area of the brain and just to create anesthesia, you'd probably just go right after the thalamus because it's a way station. So this was a bit interesting. It wasn't what we had expected. All right, so that's the first factoid. So why could this occur? So this is what we thought about at the beginning. But what we hadn't reasoned through was like what kind of inhibitory circuits, descending circuits, actually could be involved in this also. And they're very important descending circuits which project from A1 back to the brainstem areas as well as to the areas in the thalamus. And in particular, there are excitatory inputs which project onto inhibitory interneurons. So what this means is if you take out this excitatory input, which is normally there in the cortex, and there's nobody keeping that inhibitory interneuron driving, sort of modulating the activity in the thalamus there, the thalamus could become active, right? And there's evidence for this, which comes from looking at the anatomy of the area here, and also from some earlier work which is done by Tony Angel. So I'm going to skip that just for the second, but we can talk about that later if there are questions, all right? Now, so the factoid that I just want to state at the moment was the thalamus was supposedly active. Now, I just want to show you another bit of phenomenology under anesthesia, which has been known for years, and which we went to investigate in detail. So we did a second study in which we had high-density EEG, so 64 leads of EEG, on patients who we're going to increase the level, now we're going to decrease it, not just increase it and have them become unconscious. So we increase it, and then we decrease and we watch them recover. Now, it's been known since 1977, Tinker and Mitchenfelder pointed this out, that if you there's a wave that moves from the back of the head to the front. But before I mention that, it's also well known that if you close your eyes like this and you put EEG electrodes in the back of the head, you get an oscillation in the back at 10 hertz, the occipital alpha rhythm. You know, pretty much everybody has it. Maybe about 10% of people don't. It disappears as we get older, maybe gets a little weaker, but it's there. So in our studies, what we did was we had these subjects close their eyes, keep their eyes closed the whole time while they're executing the behavioral task, and then we watched the activity move forward to the front of the head when they became profoundly unconscious, and then as they recover consciousness, this moves back. All right? So this has been known for a while. So this is a little video that just shows you that. So the way to read this is the front, this is the left, this is the right, this is the back of the head. So these are two occipital leads. And so these are the spectra that are sitting in each location. So if this is 0, 10, 20, that's 30. So around 10 hertz, the person has his eyes closed. Here, eyes are closed. So on these two sides, you're seeing this occipital alpha oscillation. And if you look up here, you can see when the drug levels are changing. So no drug is being administered. And then you're going to see the wave move from the back to the front. So I'm just going to play this and just show it to you. So no drug. So now the drug is being administered. Now there's some EEG changes that are starting here now. And you can see a huge 10, maybe 15 hertz oscillation appear in the front. Now this is level 3. I'm just going to, well, I'll let it go a little further. I'll stop it right here. All right? So you can see this 10 hertz oscillation in the back is pretty much lost. And now if you start about here, which is about the center of the head, and go forward, you see how you have roughly the same dynamic here going forward, which is quite distinct from what you see in the back of the head. Okay? So there's just a slow oscillation back here. There's really very minimal slow oscillation out here, but there's slow oscillation and 10 hertz oscillation in the front of the head. I'll just let this play out. So this is the deepest level, the 5. Okay. And now, as we step back, it disappears from the front and reappears in the back. Okay. So that's anteriorization. So that's all known. There's nothing new there. This is just maybe a nice way of looking at it. All right. So in the study, what we did was, as I said, we gave increasing doses of propofol. We had 2 behavioral paradigms that we're using simultaneously to measure when people were unresponsive, was what we were calling loss of consciousness. Every 4 seconds, they had to answer a yes-no question, which was either a sound or a salient cue, which was either the person's name or a word cue. And then, just to show you really quickly, right here, where the subjects lost consciousness, you have this onset of the 10 hertz oscillation and the slow oscillation. So that's what I just want to decipher a little bit right here now. So here's what we figured out. All right. So as I said, propofol is a GABAergic drug. It acts in the cortex. It acts in the brainstem. It acts in the thalamus. And what we see, so this is from the operating room, you see this 10 hertz oscillation, and you see this slow oscillation, or delta oscillation. Right? So with the help of Nancy Coppell, there's one other little empirical fact. That 10 hertz oscillation that you saw there, it's totally coherent. In other words, it's tightly coupled. In fact, the coherence at 10 hertz is between 0.8 to 0.9 in the front of the head. So whatever's happening is happening across the front of the head. In contrast, the slow oscillation is not coherent. All right? So that was the conundrum which we had to somehow resolve. So with the help of Nancy Coppell, we did some modeling studies, and what we're able to reason through was that maybe the thalamus, in being active, was actually entraining the cortex. So we worked out a model with Nancy's help, which sort of went like the following. It's easy to have a model which can produce 10 hertz in the cortex. Okay? When you inhibit the thalamus a little bit more, the thalamus goes through a rebound hyperpolarization, and with the help of an IH current, the thalamocortical circuits will entrain. All right? This is what the model, essentially suggested. And so what we came to reason through was that what must be happening is that this 10 hertz oscillation, this coherence, could be the thalamus, like having this cortex and having the cortex entrain. So what would that mean? What would be the consequences of that? Well, the only time you hear about anesthesia in the news, right, is when we screw up, right? I mean, people love to say, oh, those anesthesiologists can't tell whether someone's unconscious, all right? So if what I'm telling you is correct, then when you see this 10 hertz oscillation in the OR like this, then you can feel pretty comfortable the person's probably profoundly unconscious, because it would be something like this. It's like me talking to you now, this very broadband communication, and if I were to take what I'm saying now and you said, okay, Emery, I want you to shrink what you're saying down to just a single frequency and one amplitude, then all of this becomes wah. Or if you give me a band, right, it would be like wah, 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 kind of like the parents, you know, like in the Peanuts cartoon. That's what they always sounded like, all right? But the key thing is, it's going to be very difficult to transmit information effectively. It's like having a hum down your phone line, all right? So that's the alpha oscillation. Now, for the slow oscillation, we did some other studies to help us sort of sort that out, okay? So Laura Lewis, who's one of my Ph.D. students, you know, worked with our neurosurgeons and neurologists. We have patients that come for surgery to have an epileptic focus removed. So they get a grid implanted, maybe some depth electrodes implanted. They stay in the hospital for 5 to 7 days. They're off medications, so they seize enough. Once they've seized enough, they come back to the operating room to have the grids removed, to have a resection. So once that occurs, you have a natural experiment in which you have patients that have electrodes in the brain, and you can actually just watch what neurons do in the human brain as someone becomes anesthetized. I mean, this is something which is done. I mean, these sorts of surgeries are done all across the, across the country and certainly in other parts of the world as well. So here's the slow oscillations that appeared right after this patient who has these grids became unconscious. And so there are two features of them that I just want to emphasize. So here's the first one. If you look right here, this red trace is being recorded at this site, the green trace is being recorded nearby, and the blue one is being recorded over here about 2-3 centimeters away. So the two sites that are close together, the slow oscillations are in sync, all right? They're basically in phase with each other. As soon as you move a few centimeters away, they're like this. They're basically out of phase. So that's the first thing. The second thing is what Laura did was she put these histograms here. If you look right here, see these right there? She made histograms to show you where the neurons were spiking. The neurons were only spiking at the minimum of these slow oscillations. So if we think of the neurons as being there to transmit information, if you have two areas that are close to each other, you can effectively communicate, because you can communicate, you can spike and then transmit within the same sort of narrow window. But as soon as you move a little bit further away, right, it's going to be more difficult to do that. So what seemingly is happening here, and I don't know the mechanism for this, I mean, this is just an empirical observation. It seems that the slow oscillation is being an indicator, in this particular case under propofol, of this sort of cortical fragmentation. Right? So you've got two things that are making it difficult for you to be conscious. You see a slow oscillation, which is a marker of the cortex fragmenting, and if you believe what I just said about the 10 hertz oscillation, the 10 hertz oscillation is creating a hum or locking the thalamus into the cortex and making it difficult to transmit information. So the anteriorization is also something that we spent a fair amount of time working on and trying to understand, because it's a major phenomenon in anesthesia. And the two-sentence summary of what we reasoned through with the help of, again, Nancy Coppell and her group, and Sujith Vijayan, who's one of my Ph.D. students who then worked with Nancy as a postdoc, is the following. The connections going from the thalamus posteriorly, let's say like to LGN, differ from those which go anteriorly. So when you actually start hyperpolarizing the posterior connections, posterior thalamocortical connections, and you start shutting down this area of the brain, there's a certain set of cells, HTC cells, which is a subset of the thalamocortical cells, which have a potential which is at about -60, all right? So when they get hyperpolarized more, they basically shut off. On the other hand, the ones that project anteriorly, it turns out that these guys, you can have this sort of rebound hyperpolarization thanks to an IH current, and so you lock into into the prefrontal area, the frontal areas, and you get an oscillation. So that's why you get sort of a shutting down in the back and why you get an oscillation in the front. And we think that this may be the mechanism for anteriorization. Now, why is it useful to point this out? And one of the reasons that I showed you at the end of that little video, in the middle there, the highly coherent pattern in the front of the head and a blue pattern in the back, because one of the ideas which has been put forth is how anesthesia creates unconsciousness is because of cortical-parietal uncoupling. So basically saying a different dynamic in the parietal area from what you see in the cortical area. Jamie Slay has done some work on this, George Mashour, Tony Huditz. So it's very, very plausible. And now you can maybe see why, because this particular dynamic, which you see with the anteriorization, has a different dynamic over the parietal occipital area relative to the front. Certainly with propofol. What happens with other drugs which are not GABAergic, I don't know. But this might be one idea of how you could explain it with propofol. So that's what I've just told you. The pathological hum for the alpha, fragmenting the cortex with slow oscillations, why the anteriorization might be related to this frontal parietal disconnect, and a key point that clinically you can see that there's a very profound effect of the drugs in the brainstem, in addition to being in the cortex and the thalamus, to contributing to the unconsciousness. All right, so I want to tell you a little bit about reanimation. Right? So this is work which has been done primarily by Ken Sol. But before I tell you about that, I just want to tell you just 2 sentences about emergence from anesthesia in general. So it's a passive process. We don't do anything to turn the brain on. We let the drugs wear off, and we try to time it based on how we see the surgeon putting on the dressing and finishing up the last few stitches and this sort of thing. But there's one thing which is very interesting if you watch people recover from anesthesia, is that it's not like recovery from coma at all. In fact, Nico Schiff and I did a little comparison of people waking up from coma, emerging from coma, and comparing to people emerging from anesthesia. And as we compared notes, we realized it's quite different. So one thing about recovery from anesthesia, roughly speaking, is that's why I've turned the brainstem upside down here. So if you turn off the drugs, you'll start to see someone coming back breathing first, and then you'll see a whole series of phenomena which don't necessarily occur in this order, but they occur to some extent, and perhaps not in all patients. But you'll start seeing people swallow and gag. You'll see them salivating, and tearing. And eventually you'll see them grimacing. And now if you check, and what's very interesting when you do that, right? So these are all signs of the brainstem returning. The EEG may be like it is down here. The EEG may be already ready to come back and sort of indicative of like an active cortex, a cortex which could be in an awake state. But what I've observed empirically, so this is just an empirical observation from Emery, right? It's not published, right? Is that the holdup very often for patients coming out of anesthesia sits right at the midbrain, right at the midbrain-pontine junction. Because, and the reason I know that is when I go back and do what I did at the beginning, when I check the oculocephalic reflex, the eyes are very often fixed, or the person has no corneal reflex. So remember, the oculocephalic is 3, 4, and 6. If you check the corneals, that's 5 and 7, all right? And then you'll actually see the corneals come back. They may be one-sided. The oculocephalic may or may not come back, and very often we end up extubating patients because they can protect their airways, but that arousal center still is not entirely back. So as we start to scratch our heads to sort of search for reasons why people might be delirious or have difficulties after anesthesia, it's probably that some of these centers are not as back as we think they are, because having them be extubated is not necessarily meaning the arousal is returned. All right. So Ken Sol started thinking about why not waking people actively or up from anesthesia. So what he did was he got some rat volunteers. And so this is one of his rat volunteers who's chilling out on his back, anesthetized under isoflurane. And he's got an IV in his tail, and he's breathing isoflurane there. And he's been there for about 20 minutes or so. And so Ken is just going to inject about just saline. So he injects the saline. The rat's still unconscious. Nothing happens. Surprise, surprise. So now about 5 minutes or so go by, and what Ken's going to do now is inject a test drug. And the test drug that he's going to inject is methylphenidate, so it's Ritalin. It's a stimulant. All right? So he injects the methylphenidate. And he has to flush it through to actually get it into the eye, get it into the animal. So he flushes it through. Now, the anesthesia is still there. The anesthesia is still going. And in fact, if he breathes more, he actually breathes in more anesthesia. He should be anesthetizing himself more. Now, he's got to turn over for this to count. It doesn't count if he doesn't turn over. But his legs are caught in the wires there. He does make it. I've seen the end of the video. You can do it again. Come on, one more. All right. So he made it. All right. So then he tells his cousin about the work that Ken is doing. So his cousin comes in. And so this time Ken implants, he gives him an IV of propofol. He's anesthetized with propofol. But then Ken then targets the ventral tegmental area in the rat's brain there. All right. He targets the ventral tegmental area with a stimulating electrode. So he's anesthetized. Now right here, Ken turns on the stimulation. Now watch what happens right here first. As soon as the stimulation comes on, see how he starts breathing? Now the propofol is still running. And he's out of there. All right. So what happened here? So in the case of the Ritalin, I mean, as you know, Ritalin blocks the reuptake of dopamine. And so what you're doing is you're basically increasing the dopamine at sort of synapses, probably all along the pathway here, coming from this ventral, not just from the ventral tegmental area, but probably everywhere else as well. Now what's very interesting about this is that Ken did as a control experiment, stimulating the VTA and also stimulating the substantia nigra. And with the substantia nigra, you get no arousal response like this, but you do get the arousal response in the VTA. So how might this be working? So it's probably something like this. So this is someone who's awake, all right? So at any given time, if you just take this neuron here, this is a pyramidal neuron, and everybody's telling him what to do. There's an inhibitory interneuron here sitting telling him what to do, and he gets all this input coming from probably other pyramidal neurons, but also certainly from these ascending arousal circuits, all right? Now, under propofol, the balance is shifted more towards inhibition here. So this guy is very grossly inhibited. Now, if you keep the propofol going, right, keep the propofol going, and now you administer Ritalin, you're not blocking the effects of the propofol, you're just shifting the balance back more towards excitation with the help of the Ritalin. Again, it's always a tug of war, whether you're in this state, that state, or whether here. And so here the balance has been shifted more towards excitation. All right? So this is what Ken is looking at now, and he just started doing trials of this in humans as a way to maybe have people come out of anesthesia. I mean, we spend a lot of time keeping you anesthetized, and perhaps one of the reasons that we may have a lot of cognitive dysfunction after anesthesia may relate to the fact that we keep the brain turned off, but we keep it turned off in a way which is not physiologic. Okay? You don't sit around in a 10 hertz oscillation between your thalamus and the cortex, when you're doing resting state. All right? So that's probably not a good thing. In fact, I'm surprised there's not more dysfunction given, what we've sort of learned from this. So that's the summary. So maybe using a drug like this for the purposes of inducing reanimation may be possible, or something in this class. All right? So this is what I've told you. Propofol alters arousal states in the brain by creating very, 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 very strong dynamics. And these dynamics make it difficult to transmit information. So as we understand these dynamics better, we could most likely get a better understanding of mechanisms of anesthesia, certainly have better ways of monitoring the brain, And then as we think through and realize that some of these things are not what we probably want to do, perhaps come up with better ideas for creating, the states of general anesthesia and sedation, which is one of the reasons why I think it's so important to get, as I said, you young guys involved in this. Thanks a lot.
All right, guys, so we've still got time for some questions.
Good question.
Yeah, right. So thank you for the good talk, but excellent talk. The first one was what affects individual variability, in your opinion? And the second one was, does that reversal that you just showed at the end also affect that anteriorization you showed earlier? As in, does it hit it back
Would it
or
send
not?
it back? So to answer the first question, the individual variability, the range in which we're operating in here, there is individual variation, but the dynamics that you see there robustly appear pretty much across most patients in the operating room in terms of the EEG dynamics that I'm showing you, how they respond to the drugs. Now, so let me just give you two extremes. So if you have a kid who's on Ritalin who comes in and you don't know it, and you start anesthetizing them, you will see it'll take more propofol to anesthetize them because their circuits are actually quite revved up. By the same token, if you have someone who's stone cold drunk and they've smashed their hand through a window and they need anesthesia because they need to have their tendons repaired, you need about that much propofol to induce them because their brains are basically anesthetized. So those sorts of things, we typically see. Older people need less anesthesia to achieve effectively the same brain states. But it's not like there's this huge kind of genetic variability that all of a sudden, we're like all over the place. Pretty much anybody you can anesthetize with about 150, 200 milligrams of propofol, roughly speaking. I mean, just to give you some idea. Now, as far as the reversal there, if the person is too deep, that reversal won't work. Right, so they have to be on the on the exiting limb. So if you have them in burst suppression, or maybe deep, slow oscillation and 10 hertz oscillation, it won't work.
Thank you. Thanks very much.
Back.
There's a question over here. Yeah.
So at the beginning of the talk, you talked about some of the behavioral mechanisms, behavioral functions that they can't do, so they don't remember or any of those.
Mm-hmm.
Have you experienced some patients that do remember or do feel pain and look at the brain dynamics in those cases?
So I personally have had one case of awareness since I've been practicing. I've been practicing, on staff since, 92. And I had one case of awareness, and it was because we used to do intraoperative radiation in patients. And so they would have the surgery to open them up, like in the operating room. Then they'd have to travel through the hospital for almost 20 minutes to get to the site where the radiation was going to be given. And during that time, the anesthetic, basically is very difficult to maintain the anesthetic state, essentially. And so that gentleman came back and said that he was aware of the whole trip, basically through the hospital. All right. But I emphasize this point here. In these cases which come up that, make the New Yorker, or that make the Atlantic Monthly, and people talk about patients having awareness under anesthesia, they never show you that they were monitoring their brains and they brought them down to and had those sorts of dynamics, right? Or there are cases that occur when people are using like indices or what have you. The indices don't give you as much information as looking at the raw EEG pattern. In fact, Jamie Slay wrote an editorial about this, about the importance of having people read the raw EEG and read basically the spectrogram. It's totally tractable. It's totally doable. And you can know. And again, as we start to fill in the more details, that's why I put all those references up there. We're going to know a lot about the brain under anesthesia in very, very shortly. But what we have to make sure happens is that it translates into practice, because anesthesiologists are not trained in neuroscience. We're trained in pharmacology, we're trained in physiology.